Khushi Jain, rule number 38. Anti-epileptic drugs. Epilepsy is a Greek word that means convulsion. Epilepsy is a disorder of brain function characterized by paroxysmal cerebral dysrhythmia. Major types of epilepsy are generalized seizures and partial seizures. Generalized seizures. First, generalized tonic-clonic seizures, that is grand mal epilepsy. It is characterized by the following sequence of symptoms: aura, epileptic cry, loss of consciousness, fall to the ground, tonic phase, clonic phase, period of relaxation, post-epileptic automatism with confusional states. Second, absence seizures, that is petit mal epilepsy. It is characterized by sudden onset of staring, unresponsiveness with momentary loss of consciousness. Third, myoclonic seizures. It consists of single or multiple sudden, brief, shock-like contractions. Next, partial seizures. First, simple partial seizures. The manifestations depend on the region of cortex involved. There may be convulsions or paresthesia without loss of consciousness. Second, complex partial seizures. It is characterized by aura, amnesia, abnormal behavior, and automatism with impaired consciousness. Next is chemical classification of anti-epileptic drugs. First is hydantoins, that is phenytoin, fosphenytoin. Second, barbiturate, phenobarbital. Third, iminostilbenes, carbamazepine, oxcarbazepine. Fourth is carboxylic acid derivatives, sodium valproate, divalproex. Fifth is succinamide, ethosuccinamide. Sixth, benzodiazepines, lorazepam, diazepam, clonazepam, clobazepam. Seventh, others: lamotrigine, topiramate, gabapentin, pregabalin, tigabayne, vigabatrin, zonisamide, levetiracetam, lacosamide. Clinical classification of anti-epileptic drugs. For generalized tonic-clonic seizures, preferred drug is carbamazepine, sodium valproate, phenytoin, phenobarbital, and alternative drugs are lamotrigine, topiramate, primidone, gabapentin, and levetiracetam. Second, for simple partial seizures, preferred drug is carbamazepine, phenytoin, sodium valproate, and alternative drugs are gabapentin, lamotrigine, topiramate, tigabayne, and zonisamide. For complex partial seizures, preferred drug is carbamazepine, sodium valproate, and phenytoin, and alternative drugs are gabapentin, lamotrigine, topiramate, tigabayne, levetiracetam, and zonisamide. For absence seizures, preferred drug is sodium valproate, ethosuximide, and alternative drugs are clonazepam and lamotrigine. For myoclonic seizures, preferred drug is sodium valproate and alternative drug is clonazepam, lamotrigine, and topiramate. For status epilepticus, preferred drug is lorazepam, diazepam, fosphenytoin, phenytoin, and phenobarbital, and alternative drug consist of general anesthetics like midazolam and propofol. Mechanism of actions of anti-epileptic drugs. Drugs like phenytoin, fosphenytoin, carbamazepine, oxcarbazepine, sodium valproate, lamotrigine, topiramate, zonisamide, lacosamide, they bind to the voltage-dependent sodium channels and prevent further entry of sodium ions into the neurons and inhibit generation of repetitive action potential, therefore prevent or reduce spread of seizure discharge. Phenytoin. Phenytoin is one of the most commonly used anti-epileptic drugs. It has a selective anti-epileptic effect and does not produce significant drowsiness. Mechanism of action. Phenytoin acts by stabilizing neuronal membrane and prevents spread of seizure discharges. The sodium channels exist in three forms: resting, activated, and inactivated states. Phenytoin delays recovery of the sodium channel from inactivated state, thereby reduces neuronal excitability and inhibits the high frequency firing. At high concentration, phenytoin inhibits calcium influx into neuron, reduces glutamate levels, and increases response to GABA. Pharmacokinetics. Phenytoin is absorbed slowly through the GIT, widely distributed and highly, about 90%, bound to the plasma protein. It is almost completely metabolized in liver by hydroxylation and glucuronide conjugation. Repeated administration of phenytoin causes enzyme induction and increases the rate of metabolism of co-administered drugs. Phenytoin exhibit dose-dependent elimination, that is, at low concentration, elimination occurs by first-order kinetics and plasma T half is 10 to 24 hours. As the rate of administration increases, the metabolizing enzyme gets saturated. Kinetic changes to zero order and plasma T half increases to 60 hours. The plasma concentration increases markedly with slight increase in dose resulting in toxicity. Hence, therapeutic monitoring of phenytoin is essential for adjustment of dosage. Uses: phenytoin is used for the treatment of generalized tonic-clonic seizures, partial seizures, trigeminal and other neuralgia. Status epilepticus, that is, phenytoin is administered intravenously in normal saline. Adverse effect: phenytoin has dose-dependent toxicity. The adverse effects are hypertrophy and hyperplasia of gum due to defect in collagen catabolism seen on chronic therapy and can be minimized by proper oral hygiene. Hypersensitivity reactions include skin rashes, neutropenia, and rarely hepatic necrosis. Hirsutism due to increased androgen secretion. Hyperglycemia due to decreased insulin release. Megaloblastic anemia due to folate deficiency, osteomalacia due to increased metabolism of vitamin D, hypocalcemia due to decreased absorption of calcium from the gut, and fetal hydantoin syndrome, that is, cleft lips, cleft palate, digital hypoplasia, etc., due to use of phenytoin during pregnancy. At high concentration, phenytoin may cause the following side effects. CNS includes vestibulocerebellar syndrome, that is, vertigo, ataxia, tremors, headache, nystagmus, psychological disturbances, etc. occur on chronic therapy. Second, CVS. Hypotension and cardiac arrhythmias may occur on IV administration. Extravasation of the drug causes local tissue necrosis. Third, GIT, that is nausea, vomiting, and dyspepsia can be minimized by giving phenytoin after food. Next is fosphenytoin. It is the prodrug of phenytoin which is converted to phenytoin by phosphatases. Dose of phenytoin is expressed as phenytoin equivalents, that is PE. It is available for IM and IV administration. It is used in status epilepticus. It is less cardiotoxic when compared to phenytoin. Fosphenytoin can be administered in normal saline or glucose. It has significantly less irritant effect on the veins than phenytoin. It is preferred to phenytoin in status epilepticus because of the above advantages. The rate of IV infusion should not exceed 150 mg PE per minute. Hypotension and cardiac arrhythmias may occur with rapid administration. Next is carbamazepine. Carbamazepine is chemically related to tricyclic antidepressants. Mechanism of action: like phenytoin, carbamazepine slows the rate of recovery of sodium channels from inactivation, thereby reduces neuronal excitabilities. Pharmacokinetics: carbamazepine is absorbed slowly and erratically from GIT, binds to plasma protein, is well distributed in the body including the CSF, and metabolized in liver. One of its metabolites retains anticonvulsants activity. Repeated use causes enzyme induction and reduces the effectiveness of the drug itself, as well as that of valproate, phenytoin, lamotrigine, topiramate, oral contraceptive pills, etc. Adverse effect: the common adverse effects of carbamazepine includes sedation, drowsiness, vertigo, ataxia, diplopia, blurred vision, nausea, vomiting, and confusion. Hypersensitivity reactions are skin rashes, eosinophilia, lymphadenopathy, and hepatitis. Rarely, it causes bone marrow depression with neutropenia, aplastic anemia, and agranulocytosis. On chronic therapy, it may cause water retention due to release of ADH. Uses: carbamazepine is one of the most commonly used anti-epileptic drugs. It is the drug of choice in GTCS and partial seizures. It is also the drug of choice in treatment of trigeminal neuralgia. It inhibits high-frequency discharges. The other drugs useful are phenytoin, gabapentin, TCA, etc. Other treatment options are surgical division, Cryosurgery, injection of alcohol or phenol in close proximity to nerve or ganglia. It is not effective for diabetic neuropathy. It is used in the treatment of acute mania and bipolar disorders. Next is oxcarbamazepine. Oxcarbazepine is an analog of carbamazepine. Mechanism of action and therapeutic uses are similar to carbamazepine. It is a prodrug and is converted to active form after administration. Its enzyme-inducing property is much less. Hence, drug interactions are few. It is less potent and less toxic than carbamazepine. Phenobarbital is a barbiturate and was widely used as an anti-epileptic drug. Its use has declined because of availability of safer drugs. It acts by potentiating GABA. Phenobarbital is absorbed slowly but completely after oral administration. About 50% is bound to plasma protein. Repeated administration causes enzyme induction and reduces the effectiveness of co-administered drugs. Adverse effects. The most common side effect of phenobarbital is sedation, but tolerance develops gradually with continued administration. The other side effects are nystagmus, ataxia, confusion, megaloblastic anemia, and skin rashes. On chronic therapy, it may cause behavioral disturbances with impairment of memory in child. Uses. Phenobarbital is effective in GTCS and partial seizures. It is the cheapest anti-epileptic drug. It is also useful in the prophylaxis treatment of febrile convulsions. In status epilepticus, phenobarbital is injected intravenously when convulsions are not controlled with diazepam and phenytoin. Next is ethoxamide. It is effective for the treatment of absence seizures. It acts by inhibiting T-type calcium current in the thalamic neurons. It is absorbed after oral administration. The common side effects are GI disturbances like nausea, vomiting, and anorexia. The other side effects are headache, hiccups, eosinophilia, neutropenia, thrombocytopenia with bone marrow depression, and rarely skin rashes. Valproic acid. Sodium valproate is broad spectrum anti-epileptic drug. Mechanism of action. Like phenytoin and carbamazepine, valproate delays the recovery of sodium channels from inactivation. Like ethoxamide, it blocks T-type calcium current in thalamic neurons. Increases the activity of GABA in the brain by increased synthesis of GABA by stimulating GAD enzyme. Decreased degradation of GABA by inhibiting GABA T enzyme. Pharmacokinetics. Valproate is rapidly and almost completely absorbed from the GIT, highly bound to plasma protein, metabolized in liver and excreted in urine. Adverse effects. The common side effects related to the GIT are nausea, vomiting, anorexia, and abdominal discomfort. CNS side effects include sedation, ataxia, and tremors. A rare but serious complication is fulminant hepatitis, hence avoided in children below 3 years of age. Monitoring of hepatic function is essential during valproate therapy. Elevation of liver enzyme occurs. Teratogenicity. Orofacial and digital abnormalities, neural tube defects with increased incidence of spina bifida, so it should not be given during pregnancy. The other adverse effects include skin rashes, alopecia, and curling of hairs. Acute pancreatitis may occur rarely. Uses. Sodium valproate is highly effective in absence, myoclonic, partial, and generalized tonic-clonic seizures. Other types of valproate are mania, bipolar disorder, and migraine prophylaxis. Divalproex. It contains valproic acid and sodium valproate in 1:1 ratio. It is administered orally. It causes less GI side effects than valproic acid. Next is diazepam, lorazepam, clonazepam. Diazepam and lorazepam are effective in controlling status epilepticus. Clonazepam, a long-acting benzodiazepine, is used in absence of myoclonic seizures. Intravenous diazepam is used in the emergency treatment of status epilepticus, tetanus, eclamptic convulsions, febrile convulsion, drug-induced convulsions, etc. Diazepam has a rapid onset but short duration of action. Hence, repeated doses are required. Diazepam can be administered rectally in children during emergency. Lorazepam is preferred in status epilepticus because it has rapid onset and long duration of action. Second, it has less damaging effect of injected vein. For mechanism of action, it is already discussed before. Adverse effect intravenous diazepam and lorazepam may cause hypotension and respiratory depression. The main side effect of clonazepam are sedation and lethargy, but tolerance develop on chronic therapy. Other side effects are hypotonia, dysarthria, dizziness, and behavioral disturbances like irritability, hyperactivity, lack of concentrations, etc. Newer anti-epileptics. These are lamotrigine, topiramate, zonisamide, lacosamide, gabapentin, pregabalin, tigabayne, virabatrine, and levetiracetam. These are administered orally. Important features are discussed below. First, lamotrigine. Mechanism of action delays the recovery of sodium channels from inactivation. Use as monotherapy or add-on therapy in GTCS, absence, myoclonic or partial seizures. Adverse effects and other important points. First, sedation, ataxia, headache, nausea, vomiting and skin rashes. Second, enzyme inhibitor like sodium valproate increases its plasma concentration. Third, enzyme inducer like carbamazepine, phenytoin, etc. decreases its plasma concentration. Second is topiramate. Mechanism of action is delays the recovery of sodium channel from inactivation, increases GABA, decreases glutamate activities. Uses can be used as monotherapy in GTCS, myoclonic and partial seizures, migraine prophylaxis and chronic alcoholism. Adverse effects and other points include sedation, ataxia, weight loss, nervousness and confusion, and it also reduces the effectiveness of oral contraceptives. Next is zonisamide. It delays the recovery of sodium channels from inactivation. Uses as an add-on drug in simple partial and complex partial seizures. Adverse effect and other important points include ataxia, headache, sedation and nervousness, and structurally related to sulfonamide. Lacosamide. It delays the recovery of sodium channels from inactivation and it is used as an add-on drug in refractory partial seizures. Side effects include dizziness, diplopia, ataxia and cardiac arrhythmias. Next is gabapentin. Mechanism of action: it acts by releasing GABA. Uses: used as adjunct in partial seizures, diabetic neuropathy, bipolar disorders, post-herpetic neuralgia, prophylaxis of migraine. Adverse effects include sedation, fatigue and headache. Drug interactions are rare. Pregabalin acts by releasing GABA, useful in partial seizures and neuralgia, skin rashes and sedation. Tigabayne inhibits the uptake of GABA into neurons, thus increases GABA activity. Uses: it is used as an add-on drug in the partial seizures. Adverse effect includes sedation and dizziness. Next is vigabatrin. Increases GABA activity in brain by inhibiting GABA transaminase as an adjunct in partial seizures. And side effects include visual disturbances, sedation, confusion and psychosis. Next and the last is levetiracetam. The mechanism of action is not known and it is used as an adjunct in GTCS, partial and myoclonic seizures. Side effects include sedation, dizziness and fatigue. Status epilepticus. It is a medical emergency and should be treated immediately. It is characterized by recurrent attacks of tonic-clonic seizures without the recovery of consciousness in between or a single episode. Lasts longer than 30 minutes. Treatment: hospitalize the patient, maintain airway and establish a proper IV line, administer oxygen, collect blood for estimation of glucose, calcium, electrolyte and urea, and maintain fluid and electrolyte balance. Total daily dose and drug interaction of anti-epileptics. First, phenytoin is the drug and dose is 200 to 400 mg interaction. Phenytoin interacts with oral contraceptive pills, steroids, vitamin D, theophylline, etc. Phenytoin induces microsomal enzymes and enhances the breakdown of OC pills, vitamin D, steroids, etc. Reduces the effectiveness of co-administered drug. Second, phenytoin interacts with carbamazepine. Mutual induction of metabolism and reduced plasma concentration of both the drugs. chloramphenicol, INH, warfarin interaction with phenytoin. These drugs inhibit the metabolism of phenytoin, plasma concentration of phenytoin increases, and phenytoin toxicity may occur. Next is carbamazepine. Dose is 600 to 1200 milligrams. Interaction. Carbamazepine interacts with phenytoin, phenobarbital, sodium valproate, oral contraceptive pills. First, carbamazepine induces the metabolism of these drugs and reduces their effects. Second, INH and erythromycin interaction with carbamazepine. These drugs inhibit carbamazepine metabolism. Carbamazepine toxicity may occur. Next is phenobarbital. Dose is 100 to 200 milligram. Interaction of phenobarbital with oral contraceptive pills, warfarin, grazophilbin, and theophylline. Phenobarbital induces the metabolism of these drugs and reduces its effect. Ethosuximide. Dose is 500 to 1500 milligram. Its interaction with valproate. Valproate inhibits the metabolism and increases plasma concentration of ethoximide. Sodium valproate. 1500 to 2000 milligram. Interaction of sodium valproate with phenytoin. Phenytoin toxicity can occur due to displacement interaction. Sodium valproate in interaction with phenobarbital. Valproate inhibits the degradation of phenobarbital and increases its plasma concentration. Sodium valproate interaction with carbamazepine increased incidence of teratogenicity when administered simultaneously.